This webinar is hosted by the Justice Community Opioid Innovation Network, which is an initiative funded by the National Institute on Drug Abuse through the NIH HEAL initiative. My name is Joel Johnson, and I am a part of JCOIN-CTC, as well as the president and CEO of TASC in Illinois, and I'll serve as your moderator today. JCOIN is working to study and disseminate solutions to improve care and outcomes for individuals with substance use disorders who are in the justice settings. Today's session is a part of JCOIN Speaker Series, where we will feature priority topics identified by the field and the latest science and innovations on the ground. So today we'll discuss the benefits of implementing medication-assisted treatment for opioid use disorder in correctional settings, including the impact of these medications and how they have the impact they have on reducing recidivism rates. Our speakers will also discuss promising practices in program design to help limit medication diversion and provide guidance designed for correctional professionals and lawmakers around implementing medication treatment in jails and prisons. First, we'd like to hear from our colleagues and funders at NIDA. Dr. Lori Ducharme is the science officer for JCOIN Initiative, and she's at the National Institute on Drug Abuse. Lori?
Thanks, Joel. And so hello, everybody, and thank you for joining us today for a webinar that we are really excited about. So as many of you know, the work that we are doing in JCOIN is focused on figuring out what works to address the overdose crisis generally and opioid misuse specifically within criminal legal systems and their populations. But it's not only that we want to identify effective clinical interventions, we also recognize that if these interventions are to be widely implemented and sustained over time after these research projects are over, then we need to identify and address very practical and pragmatic concerns about how they fit within these real world settings and real world constraints, and whether they lead to outcomes that are of high priority for the segments of the criminal legal system in which they are being tested. And we take that responsibility very seriously. And so I'm happy for you to hear today from Dr. Friedman and Dr. Evans on behalf of their team at the Massachusetts JCOIN Research Hub. You will hear how they have taken on this challenge by really engaging with the jails that are participating in their research, and that they have very intentionally collected and analyzed their data in a way that answers these practical and high priority questions from both a public health and a public safety perspective. And so that means, as you will hear, that they are focused not only on measuring outcomes such as retention in treatment and reduction of overdoses, but also equally importantly on issues including how to prevent diversion of MOUD among individuals while they're incarcerated and measuring their recidivism outcomes post-release. They are a really nice example of the way that we had hoped the JCOIN trials could effectively address overdose prevention in a public safety context. And so thank you again for joining us. And with that, I'm going to turn it back to Joel to formally introduce our speakers.
Thank you, Lori. Appreciate it. Our speakers today are first is Elizabeth Evans. Dr. Evans is a professor in the Department of Health Promotion and Policy at UMass Amherst School of Public Health and Health Sciences. She researches how healthcare systems and public policies can better promote health and wellness among vulnerable and underserved populations, particularly for individuals at risk of opioid and other substance use disorders. Her current research focuses on how the criminal justice system can impact health outcomes. She is one of the principal investigators of the JCOIN Massachusetts Clinical Research Center, as Lori indicated, which partners with 7 jails in the state to test the effectiveness and implementation of programs to expand access of medications to treat opioid use disorders. So we want to welcome Dr. Evans. And then Dr. Friedman. Dr. Peter Friedman is the Chief Research Officer at Baystate Health and Associate Dean for Research at the University of Massachusetts Medical School, Baystate. He is a primary care internist, addiction medicine clinician, and established substance use disorder researcher who has published over 150 peer-reviewed articles on the organization of treatment services, treatment process and outcomes, implementation of evidence-based practices for substance use disorders, in medical, specialty, addiction, and correctional settings, and the role of physicians in the care of patients with SUDs. He is also one of the principal investigators of the JCOIN Massachusetts Clinical Research Center. Let's welcome both Dr. Evans and Dr. Friedman.
Well, thank you. It's a pleasure to be here and see everyone. I looked through the list, a lot of friends here. So let's just jump right in. We're going to talk about two major projects, aspects of our work on strategies to reduce recidivism and prevent medication for opioid use disorder, or MOUD, diversion in jails and prisons. Next slide.
Yeah, so I also want to thank everyone for joining today, and NIDA and the Addiction Policy Forum for hosting us. And we're so excited to see so many of you here joining us. We really appreciate interest, and we're so eager to share what we're learning on our study. I think most people on this seminar are very familiar with the current context. So there is this need to provide medications for opioid use disorder in jails and prisons. And that's really driven by the current opioid overdose epidemic. We saw this past year had some of the highest overdose deaths than we'd ever seen before. I know here in Massachusetts that that's continuing for 2023 as well. There's also been studies, well-cited studies, documenting that the high risk of overdose after exit from jails and prisons, pointing to the justice system as a place where we could think about how do we implement and deliver medications for opioid use disorder, these FDA-approved medications that have been shown to be very effective at reducing overdose in the community. Yet historically, very few of these justice settings offer these medications, and that's really changing. And so here in Massachusetts, that's been changing quite a bit, which is the context for our JCOIN, Massachusetts Justice Community Opioid Innovation Network study. And as we started kicking off our study, we really heard interest in knowing more about what would be the impact of providing these medications on recidivism after people leave jail. And also, what about these concerns about these medications being diverted while people are living inside of jails and prisons? And so those are our two topics for today. They really are, like what Lori said in the introduction, questions that have come from the field, and are very practical, pragmatic issues that we want to talk over more today with all of you and share what we've learned. So we're going to go to Pete, who's going to talk on the first question.
Yeah, so these are very pragmatic questions that are really of great concern to our correctional partners and others. So this, we're going to talk about a paper that was published last year in Drug and Alcohol Dependence on recidivism and mortality after in-jail buprenorphine treatment for opioid use disorder. Next slide. So this study was actually a supplement to work that we were doing in rural parts of Massachusetts, New Hampshire, and Vermont. And what the study was is it took advantage of a natural experiment in two rural counties in the western part of our state. Most folks are not as familiar with the Western Mass, but Franklin County and Hampshire County are two counties that are very similar in sort of in their populations. And in 2015, the Franklin County House of Corrections was one of the first facilities, first jails in the country to begin providing buprenorphine in their House of Corrections or jail. We'll use those terms synonymously, in addition to naltrexone. And they provided buprenorphine induction and continuation at jail entry. They initially had focused on sentenced folks, but later included pretrial folks. And the Hampshire jail, when it did provide medication, they provided naltrexone, mostly at the time of exit from the HOC, the House of Correction, and no buprenorphine. So we were sort of interested, and actually later in the decade, Hampshire actually began as when they began part of our larger JCOIN project, which Liz will tell us more about in a few minutes. They did begin to deliver buprenorphine, but at this point they were not, between 2015 and 2018-19. So this was a natural experiment, and we were very interested in what happened to folks coming out of these facilities. Next slide. So really, the focus is on Franklin County. It's a very interesting rural county, 73,000 population, relatively economically depressed with extensive opiate use. As I mentioned, it's a rural county, and fairly small jail. The judges are appointed, but other officials, the sheriff and the DA, are both elected. And there are 2 district courts and 1 superior court. Next slide. And Sheriff Donilon, who took office in 2011, is, we would say, has been very much a forward thinker in this arena. Started doing some co-occurring programming and trauma-informed work. They began offering the naltrexone in 2015, and then began buprenorphine maintenance in early 16, and then induction starting in 2019. And then in August 28, and then in August of 2019, they actually filed with DEA and SAMHSA to become an OTP, so to be able to deliver their own methadone. And as we mentioned, in September 2019 was when our Massachusetts JCOIN hub started its work, and they were one of our strongest initial partners. Next slide. And they really took this to heart. They have developed facilities. Once they started doing methadone, they had to have their own safe. There was a lot of discussion about what the safe, do you really need to have an alarm on a safe as is required in the federal regs when you're inside a jail, and those kinds of things. So that all required some working out, but they were able to do this. And they came up with a dispensing process for buprenorphine, which really has been a model for the country. And Liz will talk more about that. Next. So the study design, what we were interested in was this natural experiment, and we were really interested in what were the post-release outcomes of folks who had opiate use disorder and who exited these 2 facilities between January of 15 and April of 2019. Within the jail, staff identified folks who had opiate use disorder, and both of these facilities did have mechanisms for screening. And then the jail staff would contact the individual, and we would be allowed to do a follow-up interview by telephone. In cases where we could reach people and bring them in person, we tried to collect some saliva and blood samples. And then the part that I'm going to talk about today is we secured administrative data, so electronic records on all the participants, both the National Death Index and their jail records. So and today we're going to talk a little bit about rearrest and arraignment and other things that went on. And we were interested in what the trajectories of opiate use were 1 and 4 years after jail, and then some of these other outcomes around recidivism and mortality, which are what I'm going to talk about today. Next. So we define the sample as adults with OUD who exited during that time period, whether or not they received MOUD. And then we pulled indicators of recidivism in Massachusetts using the criminal justice records. We had a total N of about 469, and we required them to have at least 1 year of observation after jail exit. Next slide. So the sample baseline, we had 197 from Franklin and 272 from Hampshire. The Franklin facility did have some women, a small number of women, so but you can see there's still a very high number of men. And otherwise, the demographics are pretty similar, a great majority white, and folks in their mid-30s. Next slide. So during the index episode in the jail, Hampshire had a larger number of folks on the left who were sentenced as opposed to pretrial. About 40% of their population was sentenced versus 20% at Franklin. But in terms of the number of days being held or incarcerated, they were fairly similar, approximating 80 days. Next slide. And what this shows is what folks receive. So in Franklin, 86% of folks in the sample received buprenorphine. About 7% got naltrexone. Another 6% were undocumented. And the difference in Hampshire is 100%. This was in jail, received no medication. Next slide. So when we look at recidivism, the markers of recidivism, there were significant differences in reincarceration, 39% of those in Hampshire versus 21% at Franklin. There was no difference in probation violations, and there was a significant increase in arraignments in the Hampshire population, about 47% versus 36% in Franklin. And when we looked at any event, which was how we defined recidivism for this study, 62% of folks in Hampshire, again, this is at least 1 year follow-up, had an event versus 48% in Franklin. Next slide. And then interestingly, when we looked at charges, so for all of the categories of charges, they were higher in Hampshire, but significantly higher for property crimes amongst the Hampshire folks. 23% had a property crime versus just under 10% of those at Franklin. Slightly higher drug-related, but not significant. And same for sort of violent offenses and others. And we thought that this was in keeping with what our hypothesis, that it really is driven by property crime, largely related to funding their drug use. Next slide. And then when we looked at days to event, there were longer periods, of course, is better, right? You want more time without an event. There was not a difference in terms of incarcerations, but in terms of probation violations and any event, again, the Franklin group went longer without having any longer without having a recidivism event in the community. Next slide. There were no differences in terms of mortality, however, but the numbers were fairly small. About 3% of folks died, and many of those events occurred pretty far out after the jail episode. So in Franklin, about 242 days versus 160 in Hampshire, but that was not significant. Next slide. And then when we adjusted in logistic models for number of prior incarcerations and whether or not they were pre-trial, the effects still remained. there was, as one would expect, pretrial folks had higher risk of recidivism and reincarceration and arraignment. And so we thought this was worth reporting, a stable effect and an important effect worth reporting. Next slide. And then we looked at survival curves. Again, for those who are not statistically minded, this is not about death. This is about time to recidivism. So the amount of time that they're in the community without having an event. And when we look at this over time, the Franklin group, again, performed much better in terms of having a 29% reduction in the risk of recidivism. Again, it reduced further 32% after controls, but with a 30% reduction is a significant improvement related, again, associated with the availability of MOUD. Next slide. So in summary, among incarcerated adults, jailed adults with opioid use disorder, their expected risk of recidivism 1 year after jail exit is lower among those who are offered MOUD during incarceration, as in Franklin, compared to those who are not in Hampshire. The association remained after adjusting for prior incarcerations, pretrial versus sentence status and age. And, we're happy to say now, and Liz will talk more about this, that all of the jails in Massachusetts do offer all of the FDA-approved types of MOUD. Next slide. So the study has a number of limitations and strengths. It's an observational study. It's not randomized. The data are based on the measures are based on administrative data. We don't have recidivism indicators outside of Massachusetts. We don't have crime data. These are 2 sites in a mostly rural setting, so it's unclear how that would relate to more urban settings. And we did not look at potential differences by site, whether it be by the number of non-MOUD services or policing practices, court processes, or other contextual factors. So those are all limitations of the study. However, it did, on the positive side, it capitalized on a natural experiment. It measured outcomes on everyone with OUD who exited during the period, and we were able to look at post-exit recidivism in relation to MOUD provision. Next slide. So it's my pleasure. I'm going to turn it over to Liz, who's going to talk more. We'll take questions at the end, so you can write them in the chat or now so you remember it, or you can raise your hand at the end. But I'm going to pass it over to Liz, who's going to talk about a lot of the work looking at how offering MOUD in jails affects medication diversion. And when we're talking about diversion here, we're talking about medication delivered in the jail turning into contraband in the jail. We're not talking about, diversionary programs, that move people from the criminal justice setting into treatment. So I just want to be clear because that language is sometimes confusing. Liz.
Okay, thanks, Pete. And so Pete just shared, findings from our study of 2 of the counties in Massachusetts and their delivery of MOUD. And now I'm going to pivot to talk about data that's provided by more of the jails who are in our JCOIN hub. And first, though, I just wanted to give a little context about our Massachusetts JCOIN hub. So here in Massachusetts, a legislative mandate was passed called the CARE Act in 2018, which required jails to implement a pilot program to provide all of the forms of MOUD starting in 2019. And so this meant, the jails came forward to be the ones to pilot test this program. And we worked with these jails, the ones marked in red on this graphic, to understand the implementation and outcomes of this pilot. And so that work is underway now. The pilot required that, these jails maintain MOUD medications that people were on as they enter jail. And if someone were to enter jail not yet on a medication, but in need of it, the jails were also required to do induction of MOUD within 30 days of release. And so we were funded by NIDA to do this hybrid, type 1 hybrid effectiveness implementation study. And that work is underway now. And today I'm going to report on some of our results from AIM-2 of our work on implementation. But understand there are these 3 big aims. And so we're just reporting a piece of some of our results today. But so that you know, the first aim of our study is to look at the outcomes of this MOUD program inside these jails. We will have data to understand how outcomes, such as post-release use of MOUD and other secondary outcomes like overdoses, use of the healthcare system or recidivism, how those things are different depending on whether folks received medication while in jail or not. And also we can look at maybe, outcomes by type of medication that people received. So that's data we're working to analyze now, and we'll report in a future, hopefully, seminar like this. Today, we're focusing on the data we collected for AIM-2. So for AIM-2, we were interested in implementation. This is a big change for most jails to create a MOUD program and to actually deliver it and to operate it. That took a lot of organizational changes. And so we were interested in documenting those and understanding, well, what are the factors that facilitate or impede delivery of MOUD in jail? And what about once people are leaving jail and being released into the community? What are some factors there at that really critical time point when people are released? How are jails working to continue care in the community? All with the aim of identifying some best practice strategies that jails and communities could use in implementing a program like this one elsewhere. And then we have a final third aim, which is all about, an economic evaluation. So what does it cost to deliver a program like this inside of jails? And what are, the cost offsets that might occur? So we're working with Sean Murphy and Catherine McAllister as some of our co-investigators, and that work is also underway that we'll be reporting on in hopefully this upcoming year. So I'm going to return to what we're learning from AIM-2 work. And this is a big effort that's been ongoing since 2019. We've collected several rounds of data from staff and patients and community treatment providers. And it didn't take too long for us to hear from many folks, especially those in the justice system, about their concerns about diversion of these medications inside of jails. And so it was this idea that, if we offer these medications inside of jails or prisons, could it happen that there will be much more diversion of those medications? And this was a reason that some correctional officials were citing as why they were reluctant or hesitant to offer MOUD treatment. And so this seemed like a great topic for us to look at more closely through our qualitative data collection as part of our AIM-2 work on implementation of the program. So what I'll present today is explained further in 2 papers that I encourage you to go read. Whenever I reread these, I know I'm the author of them, but I'm always like, oh, there's great information in here. And we could only, summarize some of the key points in a session like today. I'm hoping you really will go check out these papers. The first one on the left is what we learned by talking to staff who were working inside of the jails to implement the MOUD program. And the second paper on the right is what we learned from patients who had been treated with medications while incarcerated and had been released, and we interviewed them while they were living in the community. And so here's a little bit about our study sample. We did interview for both staff and patients, individuals in these jails that were part of the pilot program in Massachusetts. Jails represented urban, suburban, and rural communities. We did talk to 61 staff in 7 jails, collecting data in 2019 and 2020, luckily before COVID occurred. So that meant we had data we could analyze and make use of. But it did reflect probably the early days of implementation of the MOUD program. And we did have representation of staff from really all of the roles involved in implementing this program. So the leadership, the clinical healthcare staff, correctional officers, and those planning for reentry of incarcerated people. And then we also talked with patients. We talked with 38 patients. All of them had received medications while in jail. By the time we collected data in 2021, 2022, we now had 8 jails taking part in the study. So this data comes from folks who've been incarcerated in those 8 jails. And we use typical qualitative methods here. We went to each jail and met with staff, either one-on-one or in focus group type settings, using an interview guide of prompts that had been informed by a conceptual framework on the EPIS framework: exploration, preparation, implementation, and sustainment of a innovation like this. So we held these interviews, often taking an hour, maybe a little bit longer, and audio. We recorded all of these interviews. We had those data transcribed. Then we created a code book using the conceptual framework and emerging themes that came from the data. Worked in teams to code up all these data and then to analyze the data and deduce, looking for themes that might emerge from both sets of data. And here today, we're going to summarize some of those results and findings. So the first thing we heard, and I'm going to highlight here themes that were common across both staff and patients. And we were interested in, well, what are some reasons why people do divert these medications inside of jails? I think there maybe had been an assumption that people are mostly looking for ways to get that euphoric high by taking medications inside of jail in a way that they're not supposed to. But really, in talking with both staff and patients, we heard bullying, coercion, and strong arming were a main reason why people were diverting their medications, meaning they were being forced by other incarcerated people to give their medication to them. And some quotes here on the right really illustrate this. So the one in the middle from the patient, and I'm just gonna read it, says, you're waiting for that guy to come in on the unit, and that's it. You put him in a chokehold so you can get it, you can get the medication. And that, later you give him some food for the night, and then now he owes you, meaning he owes you the medication. Others talked about other reasons for diversion. So it might be that this idea of self-treatment, that the way the medication was being provided inside the jail might not have been in ways that folks were used to receiving while in the community. So this first quote from a staff person said, one individual, he was stating that his dose was too low and he was on a higher dose in the community. He was saving his dose for later in the day when he was starting to feel a little achy. So he was diverting the medication to use it for himself and kind of split his dose up from the morning and then also later in the day in the afternoon. And then others talked about wanting to divert medication because they wanted to help other people who were incarcerated. And the quote on the bottom from a patient highlights this, saying, there were people in my unit, they were coming in sick. And so me, as someone who wanted to help them out, I would bring it back to a couple people that needed it. So it's important to recognize there are these different reasons for diversion so that you as a facility can create different strategies for each of these different reasons for it happening. It did happen. People reported some people diverted also just to make money. So they could, divert the medication, sell it to others, and in that way, make money for themselves. So when we asked, well, how often is diversion happening? We heard from staff and patients that it does happen, like attempted diversion does happen, but completed diversion, like successfully diverting your medication, can be a pretty uncommon or not frequent event, or maybe even impossible to do. And this varied by site, I would say, and maybe even over time as jails, refined their programming. Some people emphasize, there always will be diversion. You're never going to get rid of it. It's always going to be something that's happening, really highlighting the need to implement strategies to reduce diversion. So it's upon staff who are operating the program to implement strategies to prevent diversion, or when it does occur, to detect that and then respond to it appropriately. And so from our work, we worked with the Addiction Policy Forum to create an infographic on what did we learn about ways to do dosing, especially for buprenorphine, to reduce the chances of diversion. And you can scan this QR code and get to this infographic. I'm going to walk through a few of the things that we learned here. And so the dosing process itself is so very important, especially when we talk about buprenorphine. And I do want to highlight that both staff and patients talked about how methadone was not often diverted. Instead, it was really buprenorphine was the medication that was more likely to be the diverted medication. And so when we talked about diversion, people were mostly referring to buprenorphine. So this is just a highlight of the dosing process that we saw observed in every jail site, and then we documented in talking with people about, well, what are some key things that need to happen to prevent diversion? And so it's important that there be this medication line, that people are brought into the dosing room where they first drink some water and maybe eat a cracker, and they're asked to sit on their hands or just sit very still so they can't fiddle with their face or their mouth or do something that would enable them to take the medication from their mouth and save it for later. That there's a correctional officer checking the patient's mouth with the flashlight, doing a mouth check. Another correctional officer is often in the room as well, looking at the other people waiting to be dosed and also observing the whole context. There's a nurse crushing up the buprenorphine tablets and putting it under each person's tongue. And this is in a timed, fashion such that each person will sit with the medication under their tongue for 15 minutes to enable the medication to take effect. Then after that happens, the patient's asked to spit out and drink some water and maybe eat another cracker too. And there's another mouth check that happens. So this process can be even more elaborate than this. I'm just highlighting here the key steps. You should go check out all the steps if you're doing this for the very first time. And I also recommend you visit jails that are actually doing this to hear and see how it gets done. Here's some photos from Franklin County House of Corrections where they invited a reporter to come in and observe their dosing process. And so these are photographs of an actual resident, receiving medication and having a mouth check done by a correctional officer. And besides the dosing process itself, there's several other strategies that jails can implement to prevent diversion of medications. And I'm going to highlight a few of those. There's also an infographic around this as well that you can go check out for yourself. And so it's so important that, there's training and education provided to the patients themselves. We heard from staff and patients, they didn't always know all of the different types of medications and how they could be similar or different from each other, but especially the importance of buprenorphine and the need to have it sit in the mouth under the tongue for a full 15 minutes. Like that's a really important aspect of the dosing process. And also that, dosage amounts have been tailored to each person's needs. So if a patient decides to divert medication and take less than what they actually need, like what effect will that have physiologically? There needs to be conversations with patients so they better understand the importance of taking their full medication as prescribed. And both staff and patients talked about, there could be these treatment contracts that get formed where there is this ongoing conversation that starts on day one and is continued as time goes on. There's also a need just to train and educate staff. For many, this is a totally new program. And also we're entering a setting where historically buprenorphine has been thought to be a contraband, a substance that's being brought into the jail illegally as a form of contraband. And now with a MOUD program like this, buprenorphine is the form of treatment. It's not contraband per se. Instead, it's a part of the treatment process. So that takes kind of a shift, I think, in the minds of staff that can be aided with more training and education. We also heard how it's important to have sufficient staff to patient ratios, especially in the dosing room. So folks talked about the need for, let's say, in the dosing room, if you have 15 to 20 patients waiting to get their medication, you need to have 2 correctional officers and 1 nurse at a minimum in the room, and probably another correctional officer observing the camera that's on the dosing process. And so this is, you need to have eyes on the patients at all time so that you can catch any diversion that's happening in the moment. Also, we learned how it's important to recognize the different reasons for diversion and to have conversations with the patients around why did they divert. And some shared how if strong arming is involved or coercion, among the different residents, that some patients might be really reluctant to share that or talk about it. You have to kind of tease that out of them by having a couple conversations around why is diversion happening. They might not feel so comfortable or able to share that in initial conversations. And finally, it's this idea of creating a therapeutic environment. So we're here to, staff talked about working to create a setting where patients can trust, especially the healthcare professionals, to be providing treatment that's in the patient's best interest, and creating, a setting where patients receive respect and can receive treatment with dignity. Okay, and also a part of recommendations that came out of the insights we heard from staff and patients was the need to plan for consequences for diversion. So, remember, some of this data was collected in the early days of the program before some staff maybe were ready to really address diversion as much as they probably ended up having to address it. And I just highlight this because in the early days, some facilities had sort of bare bones plan for if diversion happens, what will we do? But as time went on, I think we observed how that was a part of the program that jails did refine. And it's important to have a program that can offer graduated consequences for when diversion happens. So in recognition that these medications are an essential health service, both staff and patients shared witnessing it would often happen. Let's say that you are caught diverting, there will be some discussions around why that's happening, maybe some warnings. You might be under increased surveillance when dosing is happening, maybe one-on-one dosing even. If it happens again, another diversion event, then you might be looking at a reduction in your dosage amount. If it were to happen again, like a third time, there might be, the person being sent to the isolation or segregation setting, or sometimes it's called the hole. If it were to happen again, then maybe there's discussion around switching the medication type to methadone, something that's less easily divertible, or maybe even to other types of buprenorphine, like the injectable form of buprenorphine. And so there's a couple of quotes here kind of highlighting this. Especially, from the staff, it's from a correctional officers that, we as members of the security department, we wouldn't stop anybody's meds. The best we can do is gather that intel, present it to the clinical team to make a decision on whether or not to stop the medicine. And so this was something we heard, like that jail in the teams and within the jails were deciding who should be involved in talking about diversion and deciding the consequences for it. Insights from the correctional staff are really important, but ultimately decisions around the dosage amounts are to be decided by the healthcare team, especially the prescriber. Okay, and another recommendation that came from what we heard from patients and staff is this idea of offering the medication to anyone who needs it, starting from entry into jail. And so this goes back to the reminding everyone here that in some sites, they were not doing induction until folks were about to exit jail. So in settings like that, it would mean within a jail, there would be groups of people with OUD, some of whom were getting the medication. So patients who were already coming in on the medication and were being continued on it when they entered jail. And then there'd be another group of people who also had opioid use disorder, but were not receiving the medication because they weren't on it when they were entering jail on day one. And so that was recognized to be a reason why people were diverting medication or being asked to divert their medication, is that they were living in spaces where there were other folks who needed the medication but were not in the program to receive it. And so both staff and patients recognized what is represented here in this quote. If they let everybody who wanted to be on it on it, then there would never be a problem with people cheeking the medication and selling it. So cheeking is when they save it in their mouth and then can divert it. The only reason people cheek their meds is to sell it to people who want it, but there wouldn't be people wanting it if everybody was allowed to get it through the treatment program, basically. Okay, and we also talked with staff and patients about their perceived benefits of preventing diversion of medication, and universally people felt like, well, it does reduce risky behavior in the jail. There's less drug smuggling, much less contraband. There isn't a need to try to get buprenorphine smuggled into the jail because people can receive it just through the treatment program as needed. There's less conflict between jail residents and staff. Patients especially talked about when they receive the medication, they feel more calm, they're less anxious, they're less likely to be agitated or involved in fights with one another or with the staff. The program was also thought to improve just general well-being among people who are incarcerated. They're able to take part in other programming that's being offered in the jail when they're receiving these medications. And finally, people felt like this medication is saving people's lives. This was the perception among both staff and patients, especially thinking about that time immediately after release, that when folks can receive this medication while incarcerated, they're likely to continue that when they exit jail and thus can be protected against overdose after release. And then another benefit of the program from both staff and patient points of view was that the program really disrupted the contraband drug market inside of jails. And so from staff, we had a couple quotes on the left here, speaking to what I talked about it a little bit ago about how the program really changed the mentality about especially buprenorphine, from it being a smuggled contraband type of substance to a medication that's offered through a treatment program. And there was recognition that when there's access to the medication, why would somebody go to lengths to pay, smuggled drug prices to get the medication illegally? So they felt like it was a smart idea to offer the medication because it would basically kill two birds with one stone, meaning it would cut the contraband drug market and then also, help people avoid overdose after jail exit. And patient views were similar. The patients reported how the price of contraband drugs really dropped. So the value of contraband drugs was much less after implementation of the MOUD program compared to before. So there was less incentive to sell contraband drugs because you just could not make as much money. And then patients reported things like what we see the second person quote saying, I know for certain that there's a few people who went from sneaking it in, so sneaking in buprenorphine, to no longer doing it because they could receive it on their own right in custody, like through the treatment program. And others talked about it's just not worth it to try to bring Suboxone into the jail, for a form of buprenorphine, because they can just get it prescribed. Okay, so there were some limitations and strengths with this aspect of the study as well. So we studied a single time period. It is sampled all from folks who'd been incarcerated in Massachusetts. For the patients, most of them were still receiving the medication when we talked with them after incarceration. So we didn't interview people who were not still receiving treatment after exit from jail. Most of them reported that they had not been directly involved with diversion, that they had maybe observed it or heard about it inside of jail, but they themselves had not been engaged with diversion. And then there's some thoughts, we're asking about some sensitive, maybe undesirable activity. So the extent to which people report that, it's all self-report, although we worked really hard to make people feel comfortable sharing incidents of diversion. And then for the staff data, keep in mind, all of these viewpoints were during the early stages of program implementation. More recently, in this past year, we returned to all of the jail sites to collect another second wave of data about program operations. So we'll return to revisit some of these topics in the later set of data. But this study also has quite a few strengths. So it's one of the first to look at diversion of MOUD inside of jails that were implementing a treatment program using those medications. We heard from both patients and staff. These are voices that aren't always captured in research like this. It's a hard to reach population, especially the formerly incarcerated group. And so we feel like we were able to speak to a really high impact topic. Diversion is a reason why carceral settings are reluctant to provide medications. And we hope that these findings will help programs now know how to create a program that can minimize the chance of that. And so in summary of these data, diversion, from what we heard, was happening less often than both patients and staff had expected. And that was attributed to protocols that were in place to prevent diversion. Both groups felt like the MOUD program was benefiting both patients and staff. And there was this strong suggestion to offer the program to everyone who needs it immediately upon entry into jail, and not wait until people are going to be released to induct them then. And so we want to acknowledge, in taking in view what Pete shared earlier on the recidivism data and what I share now about diversion, that we recognize this is a major paradigm shift. That jails are offering these medications inside jails is a big change, but jails can do it. We do want to highlight that when the program is offered inside jails, it's associated with reduced recidivism, and that jails can work to reduce mood diversion. It does depend on how the program is designed and operated. And you can get more copies of all of our work. We just shared a few papers today, but we have many other publications you might be interested in checking out, and we can talk more. I think that's it of our presentation. We do want to thank our team. We're so lucky to have such an awesome team, multi-institutional and awesome set of superstars. We're so thankful they're part of our group. And yeah, I think that's it. Thank you.